our next speaker for this morning. He's my boss, so I'm going to behave as much as I can. I can promise. Dr. Neil Blumberg. So Dr. Blumberg is the director of the Transfusion Medicine and Blood Bank unit at the University of Rochester, Rochester, New York. He received his medical degree and residency training in laboratory medicine, hematology, and blood banking at Yale University, New Haven, Connecticut, in USA. His particular interest is in transfusion immunomodulation, and his clinical interests are also in the diagnosis and treatment of immune disorders such as autoimmune hemolytic anemia, autoimmune thrombocytopenia, stem cells, and mitigating transfusion side effects through the leukoreduction of the sterile products, and removed any stored supernatant through washing of these sterile products as well. With this, I'm going to stop here and give the mic to Dr. Blumberg.
Thank you, Majid. And thank you to the Bloodless Medicine and Surgery Society and SABM for inviting me to talk today. I know the subject of the meeting has been compassion, and I'm not going to spend any time talking about it, although it's compassionate to only give patients treatments that we know actually are efficacious and have a net benefit. And platelet transfusion, as you've heard about plasma transfusion from Dr. Burns, and as we've now found out over the last 20 years from many randomized trials, red cells, we've overly estimated the benefit of transfusion, and we've underestimated the harm. One of the topics I'm going to talk about is the ABO blood group system, which you've all heard about, but I will probably talk about it in ways you might not have heard about it before, because I think our approach to ABO, which is long tradition, has probably contributed to the harms that Dr. Burns mentioned with plasma and with platelets for sure. And I will talk about that near the end of my talk. So you often see these platelet transfusion guidelines. I will say, obviously, this is only relevant for patients who accept transfusion. Since we have a fair number of patients and a fair number of practitioners who don't want to use transfusion for one reason or the other, this may not have direct relevance. But as a hematologist and watching over the decades how, for example, stem cell transplant has been used, we know from the work of people like Dr. Patricia Ford in Philadelphia that we can do certain types of transplants without transfusion. But there are transplants that most physicians, and I think even Dr. Ford, would not do, which are the allo transplants from other donors. And that's because these patients have sufficiently high levels of complication from the drugs and from the transplant that they almost all require transfusion by standard approaches. And actually, one of the few areas of medicine where transfusion has been shown in randomized trials to be of benefit to patients, we have pretty much no trials showing that for red cells and no trials for plasma or cryoprecipitate. But for platelets, we have randomized trials that suggest that if you transfuse patients prophylactically, in other words, they're not bleeding, at counts of less than 10,000, that you will have significantly less bleeding during the course of their treatment. These are almost all patients with hematologic malignancies, such as acute myeloid leukemia or undergoing stem cell transplant. Now, we don't know what the long-term effects of these transfusion are, but bleeding, obviously, we'll all agree, is both potentially dangerous for patients, but also exceedingly upsetting to everyone, the patient, their family, the nurses, and even the doctors who may only be there for 10 or 15 or 20 minutes a day. So bleeding is something we don't want to see. Now, if we could come up with drugs that were better at treating these hematologic malignancies without causing these periods of prolonged thrombocytopenia and anemia, this would not be an issue. But we're not there yet. We're still treating acute myeloid leukemia pretty much, at least during the initial induction therapy, the same way now, with not a lot of differences than when I was in training 40 years ago. So this is the major use, and it is evidence-based. But all these other guidelines, which are basically, as I tell my residents and other trainees and technologists, are based on a bunch of people eating tuna fish sandwiches saying, what do you think? These are the numbers they came up with. And they're not unreasonable, but there's no evidence for them. And in fact, I'll show you that there's some evidence that we're doing harm with these numerical guidelines, because we know that, and most hematologists certainly know this, that the platelet count per se is not a particularly good predictor of clinical bleeding. It has its role in understanding what's going on, but you'll see patients with, for example, immune thrombocytopenia with counts of 1,000 or 2,000. They're not bleeding, and you'll see patients with counts of 30,000, who have widespread mucositis and toxic effects of drugs, and they're bleeding. So platelet count is not a terrific single predictor of what we should be doing. And there are the usual side effects of transfusion. You'll find these in any textbook that you look at, but what you won't find in hematology or transfusion medicine textbooks is what I'm going to talk about next. So prophylactic transfusion is in non-bleeding patients. Therapeutic platelet transfusion is in patients who are bleeding and have some reason to think that platelets play a role. So there's no question that prophylactic transfusions work. And in general, they make the patient feel better in the sense that they don't have to look at blood coming out of their nose or in their urinary tract. But as far as we know, probably do not affect mortality, but it may be that we just don't have large enough studies. But it turns out that bleeding is actually a rather uncommon cause of death in modern hospitals in many places in the world. And in fact, the real problem is that patients die of infection, sepsis, thrombosis, whether arterial or venous. And in fact, transfusion plays a role in that. So in general, we don't need to give a lot of platelets. We don't need to give them at higher platelet counts. And in fact, there may be reason to minimize this. In our own center, when we looked at the rate of disease recurrence and death due to hematologic malignancies, there was a strong dose effect that as we were giving more platelets for various reasons, there was an association. This is not a randomized trial. There was an association. The more platelets we gave them during induction therapy, the worse the prognosis. So a minimal approach, minimizing transfusion might be a good idea. And in fact, there are several studies looking at dose, suggesting that dose doesn't matter very much in general. But there are some problems, and these have become particularly evident in the last, let's say, 10 to 15 years. Turns out that platelets stored in a blood bank are not normal, healthy platelets. They're in a toxic stew of inflammatory cytokines in the supernatant. The platelets are highly activated, and maybe that's why they provide some benefit. But in fact, they also clearly, both in the laboratory, experimental animals, and in patients, predispose to inflammation. And this is manifested in modest clinical importance, things like rigors and fever, and that in fact they may increase bleeding. And there are now 3 randomized trials that suggest that platelet transfusions, for example, in patients with antiplatelet drugs who have head bleeds, there's a substantial increase in mortality and bleeding. And this was in the Lancet about 7 years ago. Premature newborns who receive prophylactic transfusions to prevent bleeding. The liberal arm of the study had a much higher rate. Whoops, sorry about that. The liberal arm of the study had substantially higher bleeding and mortality than the restrictive arm, using 25,000 versus 50,000 as the prophylactic threshold. And there's a rather unusual study where platelet transfusion was being used at very high doses to at least theoretically close a foramen ovale open at the time of birth, And in fact, they had a 10-fold increase in intracranial bleeding in the patients who got platelets. So this is not good news. What we're doing is causing harm. And this has caused a lot of upset and even a little disbelief, because longstanding clinical practices, we're doing some good. And in fact, we're doing some harm, and substantial harm, including mortality. So what are the alternatives? Well, some things that should be used before platelet transfusion in most clinical settings are tranexamic acid, an antifibrinolytic that I think has been discussed at this meeting. There's also some evidence that arginine vasopressin, the artificial vasopressin analog, also known as DDAVP, may in fact reduce bleeding and thrombosis in trauma patients and in cardiac surgery. One of the advantages is very important of tranexamic acid and DDAVP is, one, they have very few side effects, and two, they are absolutely dirt cheap and may be affordable even in limited resource settings. And so these are things that, unless there are contraindications, and there really are no contraindications to tranexamic acid, there are some to DDAVP. Mainly, you don't want to give it to patients who are volume overloaded or hypo, have low sodiums. But these are relatively minor contraindications. So what about platelet transfusion reactions? We've known about some of these for a long, long time. And it's been known from work from a variety of groups that the supernatant platelet transfusions contain all sorts of inflammatory cytokines. And this may, in fact, account for some of these fever and rigor reactions. But what has also been found is that platelets provide other cytokines that are inflammatory mediators. And that these platelet storage solutions, when we give them to animals, when we give them to patients, there is actually a relationship that if you look at the amount of cytokines present, that as you get into the highest 20%, the fifth quintile, the percent of transfusion with reactions goes up by 5 to 6-fold. It gets a little bit worse when we start looking at the other thing. In hematology, when we give treatments to patients that are pro-hemostatic, examples might be factor VIII for hemophilia, Kcentra, or Beriplex, the 2-7-9-10 complex, that these are have as their main side effect is they work for hemostasis, but they also can predispose to thrombosis. Patients with hemophilia, for example, who get very, very high levels of factor VIII will have an increased risk. Fortunately, not terribly common, but they will have an increased risk of stroke and heart attack and deep vein thrombosis. So platelets probably have the same sort of risks. There have been some case reports from a few years ago of stent thromboses and coronary disease fairly soon after a platelet transfusion. And so in looking at this, Ala Khurana, who some of you may know from his work on cancer thrombosis, led a study in which our group examined the rate of thrombosis after platelet transfusions. And this is an epidemiologic study. And it turns out that platelet transfusion, as you would expect, perhaps, was independently associated with both arterial and venous thromboses. And in fact, this led to mortality. Now, whether this is a cause and effect, you could argue, because this is not a randomized trial. But it was certainly the canary in the mine shaft for me, thinking about platelet transfusions and thrombosis. So we looked at our experience here in prophylactic platelet transfusion prior to mostly radiological interventional procedures. It was mostly line placements. And as you can see, these patients were not terribly, these are moderate, from a hematologist standpoint, these are moderate levels of thrombocytopenia, perhaps not for the surgeon. So we looked at several hundred patients, and what we found is in the week after these platelet transfusions procedures, the thrombosis rate was 5%, which is, about 20 times the level that are seen in hospitalizations overall. And in fact, most of these patients had cancer. There were also a mortality rate of 16%, which was very similar to a group of patients that Darrell Core studied at the Mayo Clinic. So these prophylactic transfusions, we're not attributing all of this mortality to transfusions. These are patients with very serious diseases, but there's some relationship here that's going on, and it's very worrisome. So we conclude that platelet transfusions are associated with thrombosis in a wide variety of clinical settings, and that some degree of causality is likely. And we know that while they provide some hemostatic benefit, they're also providing inflammation, and inflammation is also linked to thrombosis in animal model and clinical data. So that it may be in many situations, before reaching for a platelet transfusion, one should consider other agents that have been shown in randomized trials to be effective at preventing or treating bleeding, such as tranexamic acid and DDAVP. So I'm going to shift gears here to talk about something which you won't read about in any textbook or very few review articles, although there's growing literature on the subject. Our understanding in blood banking of what the ABO blood group goes back, over 120 years to Karl Landsteiner, and certain ideas came into popularity. And Dr. Rafai led a group writing a study, or I should say a commentary, on the notion of compatible blood products and universal donor blood products. And there's good news and bad news here. The bad news is we got this wrong. The good news is it's not going to be that difficult to fix if we find the will. And we have done this over the last 30 or 40 years in Rochester, because we have slowly begun to recognize that our old patterns of practice were harming patients. So we don't want to, in general, in immunology, if you're a rheumatologist, you don't want to give people drugs to which they have antibodies. And you don't want to give antibodies to the people who have the antigen. And the same thing's true with organ transplant, with rare exception. You don't want to give a group A kidney in general to a group O recipient. And we've been doing this with blood for a long time. We've been using AB plasma, which is incompatible with the antibodies present in 95% of recipients. We've been doing that forever. And these antigens are, for better or worse, present on pretty much every cell in the body, and there are soluble forms in plasma, either from cells that are falling apart and becoming senescent, or because they're actively secreted. And so these are ubiquitous antigens. So we can go back a long, long time to two randomized trials looking at a hematologically important problem, which is patients who become unresponsive to platelet transfusions. And this is a big problem, as I mentioned, if you're worried about bleeding, because if you can't raise the platelet count over 10,000, you have a dramatic increase in the risk of bleeding. This is called platelet refractoriness. And so these are two small randomized trials. This one came from Robert Carr and his associates in the north of England. And they actually intentionally transfused major mismatch. In other words, giving a group B platelet to a group O recipient or A recipient. And what they found was that the refractoriness rate was 10 times higher, basically giving ABO major incompatible platelets. And these patients also made more HLA antibodies. These are the antibodies that are responsible for refractoriness. We did a very similar trial, except it was a little bit different design. We just did what most places did, which was which is transfuse whatever is about to outdate without regard to ABO. And as recently as this year, the American Society of Hematology had an educational program that stated emphatically that ABO doesn't matter for platelets, which is 100% wrong. And we have the randomized trial data that's 30 years plus old to show it. And in fact, this is what happens to platelet count increments when you give ABO incompatible platelets. The first transfusion or two, not a problem, then it starts going down. And if you give plasma incompatible, minor incompatible, such as a group O platelet to an A recipient, you can start seeing poorer results with the first or second transfusion. But if you give ABO identical platelets, as we did in this randomized trial, the counts actually get a little bit better with subsequent transfusions. They certainly don't get worse. And this was work led by my wife and collaborator, Dr. Joanna M. So what's going on here in terms of platelet function? Because we're just talking about platelet numbers. So Dr. Rafai did a study that was published about 10 years ago, showing that as you expose group A platelets to O plasma, terrible things happen to the ability of these platelets to aggregate. If you get a very high titer antibody here, you get almost no platelet aggregation. So giving high titer group O platelets to A recipients is probably not a good idea. If you give very, very low titer, like maybe 1 to 60, you may in fact be in better shape. And so this may explain one of the reasons why group O whole blood, that's low titer, is safer than component therapy. Because in component therapy, we're giving blood components that are incompatible with 100% of patients in general. And this is also work from Majid's laboratory showing that ABO immune complexes interfere with the MA and to a lesser extent the R time and certainly the alpha angle in thromboelastography. And I'm about to finish. There's some very interesting work that was just published in Blood a couple of years ago from David Rowe, who's a neurologist at Columbia University. And they looked at patients who had intracranial hemorrhages and who had been taking in antiplatelet drugs. And the standard therapy is to platelet transfuse these patients. And they looked at the results with ABO incompatible versus ABO compatible, mostly identical platelet transfusions. And they found, as you would expect, crappy platelet count increments in this group, but worse yet, they had increased mortality and poor neurologic status, and the number needed to harm was 5. And so this is a typical example of what happened in the data. The mortality rate was in fact more than twofold, and poor neurologic outcomes was 15% higher. Just as a sort of final note, that the stuff that's in the supernatant of stored platelets is immunologically damaging to patients. And we have found in a randomized trial, and this is just the follow-up study, that if we wash these platelets and remove the supernatant, we can improve survival in younger, lower risk patients. So in conclusion, platelet transfusions increase morbidity and mortality in many clinical settings. This may have to do with the blood transfusion services approach to the ABO blood group, at least in part. They're pro-inflammatory and pro-thrombotic, and that leukoreduction and washing mitigate these effects. And that the only evidence of any transfusion actually helping patients is, in fact, these prophylactic platelet transfusions at counts of less than 10,000. Otherwise, there's no randomized trial data to show that transfusions actually help patients. And these prophylactic transfusions before surgery or procedures may be doing more harm than good, and that the ABO blood group turns out to be a lot more important than we thought. And that, in fact, giving ABO major incompatible platelets is probably worse than doing nothing. And I leave you with the notion that we need to believe the data, not the dogma. These are over the last 40 plus years, some of my most important collaborators, and I'll stop there.
Thank you, Dr. Blumberg. I so